if you would like, even you can just use the chat box as well. Okay, so in the last session, we already spoke in detail about the history of the cardiovascular system, in fact, and what is today, and we also had an introduction about the sessions, about the general physical examination, especially in the cardiology, how different it can be, a little bit special, I would say. And yeah, sometimes it can be a little bit difficult as well. It's not always the easiest. However, we all have to be careful. As I had said, history is to be able to, if with a good history, you will be able to arrive at a good diagnosis as well. I'm going to share my screen with everyone. Okay. So if you all will recall that in the last session, we had already summarized that a good history leads to good diagnosis. What I was taught during my medical school days was you should try to use the physical examination just to be able to confirm your diagnosis, so that by the end of the history, you are aware, okay, so what is the diagnosis? What is your possible differential diagnosis? Okay, so that is how it should be. So we had already started about the general physical examination and all, especially in cardiology, as the name itself shows that cardiovascular system. So of course, it is made of not just the cardiac, but also the vessels as well, okay? So we all have to be focusing not just about the cardiac component, also the vascular component as well. The vascular component is going to be about the vessels, the arteries, the veins and all as well. So we will try to, and sometimes, as I had said, it can even takes weeks to be able to confirm these kind of things, what we are trying to talk about. So we had already discussed as well about the different symptoms. What are the cardiac causes for that? Then there could be a lot of non-cardiac causes as well. For example, for chest discomfort, for breathlessness as well. It can even happen secondary to obesity. Otherwise, sometimes even due to anxiety as well. So one should be able to rule out all these problems. Other than that, so I had already said it is about the different, we all have to be aware, what about the different anatomical lines in the heart? So as I had said it, so for example, as we can see it clearly over here, so what are these lines? Anyone would like to give a try? Anyone would like to give a try? What are these lines? We had already summarized them before. So this is the sternal angle, right? This is the mid-clavicular line, and this is the jugular notch, or what is called as the suprasternal notch as well. And this is what is the parasternal line, parasternal and mid-clavicular line, because it is along the middle of the clavicle. Similarly, these three lines which you are seeing over here, okay, so the first one is along the axillary fossa. So this is in the mid-axillary line, anterior axillary line, and posterior axillary line, right? So once we have understood those typical anatomical lines, so because we have to be able to define the cardiac shadow, so cardiac border. So this is what is called as the apex of the heart and the base. So this might be a bit confusing for several people, what is the which area and all. So, but this is what, to make the concept more clear. So as you can see over here, this is the apex and this is the base of the heart. And in fact, even when you will be seeing on the chest X-ray as well, you should not forget that over here, the right border of the heart is made from the inferior vena cava, which you notice over here in this diagram. And this is the one from right atrium. So why this is important is a lot of times, if you are noticing on the chest x-ray as well, the right border of the heart seems to be enlarged. So start thinking, what are the conditions in which right atrium enlargement will be there, or the inferior vena cava is going to be much more prominent as well. And these intercostal spaces are a lot of times more important, not only to be able to auscultate, to be able to listen to the different heart sounds. Similarly, if someone is having a left ventricular hypertrophy, so if you may notice, this is the left ventricle, which forms the apical border of the heart. And the right ventricle is behind this. So if there is a left ventricular hypertrophy, so you will be noticing the displacement of the apical beat as well for those patients. And one of the most important landmark, which I cannot overemphasize, is the second intercostal space. So the important areas for us to be able to know is aortic area, pulmonary area, the tricuspid valve, and the mitral area. So these are the areas where we can listen to the different aortic sounds. So if you may recall, the S1 is made of, what are the components of the first heart sound?
Closure of the mitral valve.
Great. I would really suggest, if possible, to use the another chat box, please.
Okay.
It's a good one. So each heart sound, S1 or S2, has got two components. And what are those components? So, okay, let's see. Wonderful. Abby, great, great, wonderful. You are absolutely right. A mitral and tricuspid valve component for the S1, and the S2 is formed of aortic and the pulmonary valve component. And this is the reason you have to focus to those areas. So for example, if you're expecting a loud P2 or loud second heart sound, so you can try it, you can hear them better in the pulmonic area or even in the aortic area as well. So for example, the pulmonic component, so if there is a patient with a pulmonary hypertension, you may expect a louder P2 sound. So you will be there in the pulmonary area, of course, okay? So as I had already said it even in the last session as well, there are three components which we have to try to see: the cardiovascular examination, which is the general examination, then also the neck veins, and also the precordium. So I had given a short term, what is called as a PICL. So PICL stands for a mnemonic, is a pallor, icterus, cyanosis, clubbing, edema, lymphadenopathy. And other than that, the rest everyone knows: temperature, pulse, respiratory rate, and also the blood pressure. So what is pallor? So pallor of anemia is actually best seen in the mucous membrane of the conjunctivi, and also the lips, the tongue, and also in the nail beds as well, isn't it? What are the causes of anemia? Anyone would like to try? What are the common causes? So there can be a lot of common causes, someone bleeding, iron deficiency, otherwise malnutrition, otherwise increased menstrual bleeding and all these problems as well. However, in cardiology, what happens is you will be able to see iron deficiency. Good one, Amar. So especially in the cardiology, we tend to see those patients who will be coming and presenting to us with sinus tachycardia or heart failure as well due to hyperdynamic circulation. So the other common things what we see is cyanosis. It's like the bluish discoloration or the skin and mucous membrane, which is due to the reduced hemoglobin. And the reduced hemoglobin, as you can see, it's more than 5 grams per deciliter due to the reduced arterial oxygen saturation, which is caused by cardiac or pulmonary disease, in fact. So there are two types of cyanosis. One is the central cyanosis, and the other one is peripheral cyanosis. So the causes for central cyanosis tends to include the pulmonary edema, congenital heart disease, like the Eisenmenger's, Fallott's tetralogy, like that, and the peripheral cyanosis, which tends to result whenever there is a cutaneous vasoconstriction, which is slowing down the blood flow and increasing the oxygen extraction in the skin and the lips. So it may even happen secondary to the cold exposure as well. What about clubbing? So it's not the one which one does with the DJs with loud music. So there's a medical clubbing as well. So it's a painful soft tissue swelling of the terminal phalanges. And if you may notice, there are different ways how to rule it out. So you're trying to test for the fluctuation using the thumb at the base of the finger, then the index finger fixing the nail bed, and finally using the middle finger to fixate this joint over here. Okay, so this is a very good clinical sign. So sometimes even during the clinical examination, it may be even asked, how will you examine for finger clubbing? And then you can also see for the fluctuation of the nail bed or by the nail fold angles as well. So there's a sign called a Shamroth's window sign. If you juxtapose the nails of the two fingers over here, if you are able to see the Shamroth's window, it means clubbing is absent. Okay, so in normal people, you will be able to see the window because of the gap. However, if the clubbing is there, that window is going to be absent. So what about edema? So as you all are aware, in advanced heart failure, edema may involve the legs, genitalia, trunk, and there can be transudation into the peritoneal cavity as well, which can be causing ascites. So sometimes you may be able to see fluid also into the pleural cavity or in the pericardial space as well. So what is happening with this pulse? So there are different specified characteristics you should be able to calculate upon, I would say, okay? Whenever you're thinking about the description for an arterial pulse, it will be like, you should comment about the rate, how much is it, 60 per minute, rhythm, is it regular, irregular, what about the volume? Is it low volume pulse? Is it a high volume pulse? Then the character, the condition of the vessel wall, is it malleable, non-malleable? Then you should also try to also see on the equality on both the sides. And then you should try to see for radial delay or radiofemoral delay as well. And also, if you would like to go through the other pulses as well, it's always a good idea, in fact, to go through that. Then there are various maneuvers. Maneuvers means, for example, if you try to take an inspiration and an expiration, what are the different variations which you may see? So, for example, a pulse rate or the heart rate, it's a normal thing is, if you take a deep inspiration, the heart rate is going to increase. However, during the expiration, the heart rate will come down. What is the reason for that? So what is the phenomenon called as? So this is the one, if you will see on the ECG, it is called as sinus arrhythmia. And similarly, on the blood pressure as well. So on the blood pressure, in fact, on inspiration, there can be a fall of around 10 millimeters of mercury. However, on expiration, it is going to rise. As you may notice over here, and as I had said it for the heart sound as well, the split on inspiration is going to increase. So that's why a lot of times, if you're confused about the wide and fixed split, is it there, is it not there, you should try to ask the patient for a deep inspiration, and then you will be able to appreciate it much better. So regarding the causes, what happens is, I think you all are already aware about most of the common causes for this tachycardia, sinus tachycardia, bradycardias as well. Similarly, there can be a lot of times physiological causes as well. Okay. So this is a very important thing. Like, what are the causes of irregular pulse? So normally people will think like, okay, someone is having a disease like atrial fibrillation, but other than atrial fibrillation as well, if it is having a variable block, otherwise sinus arrhythmia, which I already said it as well, try to rule out those the causes. One thing I really learned in my medical school days was common diagnosis is commonly correct, rare diagnosis is rarely correct. So if there's any situation which we all come across, always try to first think of is the common diagnosis. For example, for sinus tachycardia, what about those? Initially think for the physiological causes, then you start thinking about the pathological causes. So arterial pulses as well. Normally we check for the radial pulses. However, sometimes we have to go for the brachial pulses or the carotid pulse as well. And it is very important where are the location of these pulses as well. Because whenever we are doing a coronary angiogram or even for the EP study, we have to try to take access for these vessels, and that's why it is important. Posterior tibial artery or dorsalis pedis artery as well. So for example, if you have done the angiogram, but the patient is feeling that he's really not responding well, and then you see the leg like you try to, of course, check for the peripheral pulses, like especially dorsalis pedis artery as well. So very important, okay? The blood pressure. I'm sure you would already been exposed to the blood pressure. So what are the different methods to check blood pressure? Anyone would like to try? I would like other people as well to give a try for the answers. Not just the regular ones. Come on, what are the different methods? I'll give you a hint. Auscultatory method, I'm sure you would have tried. Electronic blood pressure curve, that's not a method. Okay, there are three methods. Palpatory method. Palpatory method is what happens is you can keep your pulse. You try to check for if you're able to get a radial pulse or not. That is the one. Auscultatory method. Auscultatory method is you can listen to the Korotkoff sounds. And the last one is called as auscultatory palpatory method, auscultatory method, and the last one is oscillatory method. So for that, I will give you like a task. You should try to read about it. So very low or even 0 millimeters of mercury of diastolic blood pressure may be recorded in patients with chronic severe aortic regurgitation. This is very important. So what patients can be, there in a live patient, there can be 0 diastolic pressure. So for example, with someone with severe AR, otherwise a large atriovenous fistula because of diastolic runoff, especially in those patients. And very low diastolic blood pressure may be recorded in patients with chronic severe AR, okay, which I already said it. Okay, so arterial pressure, we all are aware, it is very important to be aware that how much is the normal blood pressure levels. Now there are guidelines as well. So these are again special topics in their own to be able to know. And it is always, so if you come across, when you are doing a physical examination of a patient, then you come across a hypertension is there. So what are the causes for hypertension? So you try to rule out the renal artery disease like the stenosis, the pheochromocytoma as well, because they are the ones which will be causing higher release of catecholamines, which will be causing hypertension, headaches, sweating, palpitations as well. Then there's Conn's syndrome. So on an overall basis, try to rule out those endocrine causes. So the Conn's syndrome is due to the tumor of the adrenal cortex, which is going to secrete the aldosterone, and the Cushing syndrome as well, which is going to release the ACTH syndrome. So some of those patients can also be having coarctation of aorta. How can you rule out coarctation of aorta? Anyone would like to try? So a lot of times in such patients, there will be difference in the blood pressure between two limbs, in the upper or the lower limbs, otherwise in the left and the right arm. So that's the reason if someone is coming for the first time, try to check the blood pressure in both the upper limbs as well, I would say. Then one of the most important things about the examination of the neck veins, the jugular venous pulse. So the fluctuations in the right atrial pressure during the cardiac cycle tends to generate a pulse that is transmitted backwards into the jugular veins. And this is the one which is best examined in good light when the patient reclines at 45 degree. And at 45 degree, the venous pressure appears just at the upper border of the clavicle. And examining the JVP by observing the level of pulsation in the internal jugular vein. And as you all know, so JVP tends to level reflects the right atrial pressure, and JVP in health should be around less than 4 centimeters above this angle when the patient lies at 45 degree. And the sternal angle is approximately 5 centimeters above the right atrium. JVP plus 5 centimeters is equal to the right atrial pressure. Okay. Anyone would like to summarize? How do you do it? So I already showed you the figures, how you do it. So you try to make someone, okay, I'll show you some of the figures. So you try to ask the person to lie on the right side, okay, patient's right side, position the patient supine and recline at 45 degrees with the head on a pillow to relax the sternocleidomastoid muscles. Look across the patient's neck from the right side. Identify the jugular vein pulsation in the suprasternal notch or behind the sternocleidomastoid muscle. And use the abdominal jugular test or the occlusion to confirm if it is JVP. JVP is the vertical height in centimeters between the upper limit of the venous pulsation and sternal angle. Okay. So a lot of times it can be confusing to how to differentiate between the carotid artery and the jugular venous pulse, because both of them can be pretty close to each other. You know, so these are the different waves of a jugular pulse: ACV, XY. So ACV are the top ones, crescents, and this is the lower ones. So what are the different components for this? What do they stand for? Anyone want to try? What are the components? I think no one is doing any pre-readings. This is what I'm assuming actually. Isn't it? No one, there's no use of giving the pre-reading materials. No one bothers. Everyone is hiding behind their devices. So what happens is A is the one for atrial systole. So atrial systole, stronger it will be, more prominent it will be. C refers to the closure of the tricuspid valve, A, C, V. And V is for the valve, tricuspid valve opening. So this is the peak pressure in the right atrium immediately prior to opening of the tricuspid valve. And what about the X and Y component? So X is due to the downward displacement of the tricuspid ring during systole. And the Y component is due to the descent at the commencement of the ventricular filling. So on different diseases, it could be different. So as you may notice, if someone is having a heart failure, so the JVP will be raised. Isn't it? Similarly, pericardial effusion, what is going to be happening is JVP will be raised, but there will be a prominent Y descent. So these signs are very, very important. Not just that, in fact, it could be even asked for your MRCP questions as well. So if there is an atrial fibrillation, there will be no A waves. Why is that? Because there's no S1 component. In atrial fibrillation, there's no P waves, right? Why there's no P waves? Because the atrial closure is going to be affected. That's the reason, isn't it? So then now coming to the precordium examination. So everything is, again, same thing. The typical system: inspection, palpation, percussion, auscultation. And there are 3 criteria which one must fulfill for a good examination. So what are those 3 components? What are those 3 criteria for a good examination? So someone should be examined in recumbent position, sitting position, and in good light. It's always important. So now coming to the inspection, what are the different components you examine during inspection? You try to see for chest wall deformity, how about the position of the trachea, the apical beat, other pulsations, the dilated and engorged veins, and also if there is any surgical or any scars as well. Because on the basis of the surgical scars and all, you will be able to comment if someone has undergone a bypass surgery, heart valve surgery, if there's something else as well. And yes, you will come across several times the chest wall or the skeletal abnormalities as well. So you will come across, there will be a precordial bulge, which I showed it to you. The pectus excavatum, it is called as funnel chest. Pectus carinatum is like the pigeon's chest. And the kyphosis is the forward bending of spine. Scoliosis is the sideward bending. Okay. S for S, that's how I used to recall. Scoliosis is the sideward bending. Yeah. And why it is important is because this can not only displace the heart, but also affect the palpation. And when you're trying to auscultate as well. So one of the important beats, which I had already said it as the apical beat, which tends to be the lowest and outermost point of definite cardiac impulse can be palpated. So there are a lot of other pulsations as well, like the arterial pulsations, the right or the left of the upper sternum as well, left upper parasternal region as well, even in the epigastrium as well, if there can be some component pulsations. If there's an aortic aneurysm, so you will be able to see those epigastric pulsations. And if someone, there's a hyperdynamic circulation, for example, in cases of anxiety, hypothyroidism, aortic regurgitation, or hypertension, you notice is arterial pulsations in the neck. Okay. And then, as I had said, it is pulsation to the right or the left of the upper sternum may be due to aortic aneurysm. And in fact, the enlargement of the right ventricle or enlarged left atrium could be due to severe mitral regurgitation, which will be causing pulsations in the left upper parasternal region. By looking at this picture, what do you think? I'm giving you guys 1 minute gap to be able to think about it. What could be the possible diagnosis? If you look carefully at this picture, you should be able to diagnose. Please feel free to use the chat box. So if you will see, there's a patient in the ward with this. Okay. Interesting diagnosis. As I said it, common diagnosis is commonly correct. Rare diagnosis is rarely correct. So what happens is, what do you notice over here? These veins seem to be typically quite a lot prominent, isn't it? However, yeah, I have not shown you the complete other side as well. Always try, rather than diagnosis, it can be sometimes difficult to arrive at. So keep differential diagnosis in your mind. Differential diagnosis for this will be a superior vena cava obstruction, inferior vena cava obstruction, or even coarctation of aorta, isn't it? So next time, if I come across a patient like this, I'll ask you guys, okay? What about the palpation? What are the components? What you try to palpate for? You try to see for the apical beat, trachea, parasternal heave or thrill as well. Then how about, is there any tender points as well? Because sometimes they will be telling, like, you know, I'm feeling pain over here, I'm feeling pain over there. Now coming to the apical beat. So the two components which is important is the position and the character. So position, I mean, is normally it will be there in the left fifth intercostal space, half inch medial to the mid-clavicular line. I hope you all will recall where was the mid-clavicular line, right? You can close your eyes, try to think about it. And then, yes, if there is enlargement of the heart due to the hypertrophy or dilatation, you will be able to notice the shift in the apical beat. Regarding the character, I mean is a normal apical impulse. It will briefly lift your finger, okay? Imagine your finger putting up on the apical beat. You'll just briefly lift your finger and is localized. However, diffuse, sustained, or even more forceful thrust will indicate left ventricular hypertrophy or hyperkinetic circulation. A tapping apical beat, we typically tend to call it for mitral stenosis. Mitral stenosis normally we come across in rheumatic heart disease patients. Nowadays, it may be a little bit less to be seen. So sometimes, even after all these things, if you're finding it difficult, you can always perform some maneuvers. Maneuvers means you can ask the patient to lean forward if you are not able to palpate the apical beat. Because sometimes what may happen is sometimes the apical beat may be behind a rib, or the chest wall may be pretty thick if someone is a pretty muscular guy or obese guy as well. And sometimes there can be conditions like the emphysematous lung, okay, or maybe there may be pleural effusion, pericardial effusion, or the uncommon diagnosis can also be is, anyone would like to try? Dextrocardia. So sometimes the heart may be on the other side. So of course, if you're trying to be there on that side when you're trying to see and palpate, you will not be able to see. Parasternal heave. So there are two components of this is thrill. So you try to palpate the parasternal heave. Normally you try to palpate with the ulnar border of the hand. So if you may be able to see in my video, so this is the radial border and this is the ulnar border. Okay. The hand has two bones, radius towards your thumb and ulnar border is towards the ulnar bone. So you have to palpate with ulnar border of your hand over the left parasternal line. Normally, parasternal heave can be present in the right ventricular hypertrophy. Then what about the thrills? Thrill is actually a palpable murmur. It is produced when the blood passes through a narrowed valve or when there is abnormal blood flow. For example, in congenital defects, or if the blood flow is rapid, or the direction, the flow in veins. So, for example, in SVC obstruction, um, uh, so above downward will be there. However, if it is IVC obstruction, of course, it will be below upwards. So now, what about the percussion? So in today's world, I must say, now we have so much sophisticated gadgets and all. So percussion, a lot of people may not even do. It may not be comfortable, especially for the patients. But you can do this. This is always good to know a lot of times. So for example, if you're going for your medical tours to some center, maybe some country where these modern tools of investigations like a cardiac echo and all those things are not there. So sometimes it can be pretty helpful as well. So you try to place the palm of your left hand on the chest with your fingers slightly separated and press the middle finger of your left hand firmly against the chest, aligned underlying ribs. Along the area which needs to be percussed. So strike the center of the middle phalanx of your left middle finger with the tip of your right middle finger, swinging movement of the wrist and not the forearm. Remove the percussing finger quickly, resonant to dull, and then you try to hear for the note. So is it dull, resonant, or tympanic? So right border, as I had already said, it is. What about the left border? So left border, as I had already said it as well, we discussed about it. I'm trying to avoid to repeat. I'm trying to purposefully not to repeat any of the topics because of the shortage of the time which we are having. So we already spoke about the first component, second component, and where do we listen to them? So with the steth diaphragm, at each site, identify the S1 and the S2 sound. Try to assess the character and intensity. You have to also notice or comment about if there is splitting and palpate the carotid pulse to time. So S1 barely will precede the upstroke of the carotid pulsation, while S2 is always out of phase with it. So with this, we'll be able to see which is the first heart sound and which is the second heart sound. So the first heart sound is the one which is always described as lub. Second heart sound is called as dub, pause, lub dub pause, lub dub pause, lub dub pause, lub dub pause. This is how you say. There are different variations. So for example, if there is atrial fibrillation, there will be no S1. Isn't it? Similarly, the S1 can be pretty loud. In what kind of conditions? So if there is a short PR, then the S2 components as well, we had already spoken. So fixed splitting, like in atrial septal defects, it will be there. So you can even draw phonocardiogram. How are the different heart sounds related to each other? You can even listen to them as well. So there sometimes it can be abnormal signs like S3 and S4 as well. So what will happen is the rapid filling occurs early in the diastole, so which is the S3, following the closure or following the opening of the atrioventricular valve. And the S4 is late in the diastole. So S3 is early in the diastole, S4 is late in the diastole. Okay. So the gallop rhythm, whenever the heart is more than 100 beats per minute, may be present. So the triple rhythm, which is produced by the addition of the third or the fourth heart sound to the normal first and second sound. And that's how you try to summarize your auscultatory findings. Other than the normal heart sounds, you also try to see if there's an opening snap or the ejection click or the mid-systolic click, if there's any pericardial rub or something. What about if there's a pleuropericardial rub as well? You should also try to comment then about the murmurs. So murmurs, normally you can auscultate if there is a turbulent flow across an abnormal valve, septal defect, on outflow obstruction. So you try to comment about the timing. Is it ejection type, or is it a systolic murmur, diastolic murmur? Duration. Is it a short murmur? Is it a long murmur? The character and the pitch. Is it a rumbling murmur? Is it a loud murmur? The location as well. Is it in the aortic area? Is it in the pulmonary area? Then radiation. So sometimes some of these murmurs can also be radiating as well. So then, of course, to summarize your findings for the cardiovascular examination, not just you try to give the details of the patient, for example, name, age, sex, and all. Then, as I already said about the general physical examination, you could try to comment if there's any pallor, icterus, cyanosis, clubbing, edema, lymphadenitis, or temperature, pulse rate, blood pressure as well. Okay. Anyone would like to comment about the differential diagnosis for clubbing? I had even shared a mnemonic last time. What are the causes for clubbing? And as I said it, this can be a question for you guys also in the MRCP examination, even if you're trying to appear for the US medical licensure examination as well, for US MLE. It can be an exam question. What are the causes for clubbing? So the Shamrod sign, I think everyone will recall, we discussed about it. So what are the causes for clubbing? Congenital heart disease, C4, congenital heart disease, L4, lung abscess, U4, ulcerative colitis, B4, bronchiectasis, I4, infective endocarditis, N4, neoplasms. It was such a beautiful mnemonic. Pulmonary edema, my friend, clubbing, clubbing will tend to happen, as you know, those things. So it will be a rare finding, you know, and something is there for a long, long term, isn't it? Only then you will be able to notice. So after you have said it, but all those then inspection, examination of the Precordium, you tell about percussion findings, auscultation findings, then finally you summarize that cardiovascular system of the subject is normal or abnormal. If you will take a step-by-step approach, you will never miss the diagnosis. So this is the beauty of the clinical examination. So clinical examination is very important. So for example, I'll try to show you pictures. What is being done in this picture? Anyone would like to try? What is happening? Carotid pulse. Okay. So Amr says carotid pulse. Toby says JVP palpation. Ojwal says JVP. Okay, good. So what happens is indeed, so this is about JVP, but it could also be for carotid as well. So inspection of jugular venous pressure should be done with a patient lying on their head tilted to the left side. Okay, as you can see in this. And the patient should be elevated to the point where JVP distension is seen in the mid neck. In a patient with a markedly elevated JVP distension, they may actually need a sitting upright position, okay? Or in a patient with a low JVP, You can even ask the patient to, completely lie down as well to distend the mid vein. Okay, so what about this picture? Oh, I have already given you the answer. So as you may notice in this figure, so the inspection and palpation is being done. Yeah. So inspection done correctly. So you, on the right side, head is tilted to the left, patient is elevated. Note, especially in a female patient, they may have the gown on, like, for example, which you can see in the picture. And the inspection, palpation, or auscultation for rest of the cardiovascular examination is done at normally at 30 degrees. You have to try to inspect in all the 4 areas. And palpation of the aortic area, especially, where is the aortic area, which we had shown you earlier? In the right second intercostal space, just lateral to the sternum. Since no one has been answering me, I will already give you the answer as well. What is being done here? So answer is in front of you. Palpation of the pulmonary area. So where is it? Where is the pulmonary area? Just knowing the answer is not enough. You should know why. What is the reason for that? So palpation of pulmonary area is being done, yes. So pulmonary area, if you may recall that figure I had shown you, it is in the left second intercostal space, just lateral to the sternum. Abby, good one, Abby. Wonderful, I'm so happy. So what are we doing over here? So you already know the answer. I have given you the answer, but why? What is being done over here? So what is happening is you're trying to palpate for the right ventricular and tricuspid area in the lower left sternal border. Okay, so that is the RV and tricuspid area. Okay. How about this? So I've already given the answer, palpation of the apical area. But why do you think this? Why do you think this? Because, so what will happen is, so palpation is done with finger pads in all 4 areas. Palpation of the apical area above the 5th intercostal space and mid-clavicular line. And yes, you tried in this position. And now still the apical impulse is not palpable. So what do you do now? We already had a discussion. A lot of times, I'll tell you, if there's a female patient, it can be a little bit difficult as well to do all these maneuvers. So that's why I'm trying to give you an example with pictures so that it stays with you in your mind. So what you try to do is, you try to do the same step in left lateral decubitus. Okay. So after doing that, what we go for is the auscultation. So auscultation is with the diaphragm you do, in what areas you do. So auscultation, you can see it, you can auscultate with the diaphragm, you can auscultate with the bell as well. So with the diaphragm, you auscultate in the aortic area, pulmonary area, tricuspid area, and the mitral area. Okay, and then also in the sitting position, you auscultate in the left lower sternal border with a patient fully exhaled. After you have done that, you try to auscultate with a bell in the mitral area, or the mitral area in the left lateral decubitus position as well. Okay, and also in the tricuspid area. No, not that I'm showing you all a female picture only. No, we can even show you some, different ones as well. So what? So yeah, that was with diaphragm. This is with bell. And finally, for equality of genders. So here, the auscultation is done with the diaphragm of the left lower sternal border, where the patient is sitting and fully exhaled. And this is the optimal position to listen for the aortic regurgitation. Okay. So are there any further questions?